Healthcare consumers, providers, creators, and advocates. Health and wellness should be everyone's top priority, and it's a dynamic topic, complex and sensitive to a vast array of factors from a local to an international scale. The healthcare industry is now at the forefront of everyday life and hopefully on the cusp of a renaissance. We're glad you've joined us for this series that explores the ideas shaping healthcare. I'm Minta Ferguson, healthcare architect and director of the Strategic Facility Planning Group, McMillan Pasden Smith Advisors. And this is Ideas Shaping Healthcare. Today I'm joined by my colleague and new podcast co-host, Mike Tanner. Mike is our senior strategist at McMillan Pasden Smith. He is a seasoned healthcare executive with over 20 years of experience in the field. He is a board-certified fellow of the American College of Healthcare Executives and holds graduate degrees in the life sciences and business administration. Throughout his career, Mike has demonstrated a strong commitment to improving the healthcare industry with a focus on operational excellence, patients' experience and outcomes, and strategic growth. He has held leadership positions at academic medical centers, healthcare systems, as well as the biotech and medical device industries. In addition to his professional accomplishments, Mike is actively involved in the healthcare community, volunteering on various boards and committees. He is a frequent presenter at industry conferences and has published in several peer-reviewed medical journals. Mike, I'm really happy to have you join the podcast.
Thank you, Minty. I'm happy to be here.
Before we dive into today's episode, please note that having someone as a guest on our podcast does not imply an endorsement of their products or services. The purpose of this podcast is to foster timely conversations and exchange ideas from varying points of views related to the ever-evolving healthcare industry. We hope that you find the information presented today informative and relevant. Thank you for tuning in, and now let's get started with the show. Proactive MD is a leader in on-site and near-site primary care, providing customized healthcare solutions to companies and their employees. Mike, would you like to introduce our guests and provide some insight into what we'll be discussing today?
Certainly, thank you. Our guests today are Troy Corley and Charles Swain. Troy is Proactive MD's Senior Vice President of Employer Engagement, and he will share insight about the care and delivery side of its healthcare centers. Joining Troy today is Charles Swain. Charles is the CEO of Foundation Property Group, which partners with Proactive MD, leading its real estate and property management efforts. Troy and Charles will be sharing their expertise on topics such as preventive care, value-based healthcare, and the role of technology in the environment and healthcare. We'll explore the ways in which Proactive MD is making healthcare more accessible and affordable for individuals and organizations alike. So join us as we dive into the world of ideas shaping healthcare with Proactive MD.
So help me understand where Proactive MD comes into the healthcare picture. So let's imagine we're in Charlotte, and we have a lot of industry that's moving into this area. We have a lot of industrial facilities, a lot of really large corporate headquarters, and all of these have quite a few employees. And I'm trying to really create the best healthcare solutions for my employee base. There's always insurance. But I want to keep them in the office. I want to keep them well, and they want to have affordable care as well. So help me understand where Proactive MD comes into this picture. What's the solution you have, and what's your why?
Yeah, that's a great question. And so at our core, we partner with employers to take great care of their employees. We're built on a foundation of primary care, and we offer the highest level of care within our health centers. So we do operate health centers within the footprint of a large employer. We also have what we call direct primary care or shared site health centers that they care for maybe a smaller employer that's not quite ready to invest in a full-time health center on site. They also take care of individuals and families in those health centers. But at our core, we're working with primarily self-funded employers. So paying all of their healthcare costs out of their pocket. And by providing this high level of primary care in our health centers, we're actually able to lower overall healthcare costs for employers. The other thing that I'll just mention is healthcare doesn't stop at the door of primary care. And one of the things that makes us unique kind of in this marketplace is we will guide our patients through the entire continuum of care. So when our patients do need a specialist, our role really is to find the highest quality specialist available, help them navigate to that care, but then also stay in the conversation. So I would say from a patient perspective, it's primary care like they've never experienced before. Our model really is built with the patient in mind. We really live by a patient promise, a commitment that we make to all of our patients. And that promise is we are only and always about the patient. And we promise to always fight for their greatest good. We talk about that patient promise all the time. We're sponsored by employers to take care of patients, but we're very clear that the patient always wins. And if they're ever in conflict, we fight for the patient's greatest good. The beautiful thing about that is you actually get better outcomes when you operate that way, and better outcomes cost the employer less money on insurance.
I really like that value proposition, and really kind of what is the total value of the care. I'm curious, for this primary care model, you're seeing those employees plus their families. So as primary care exists, there's also kind of this urgent care piece to it. And then on the other end of the spectrum, there's also these concierge models. And do you have an urgent care option as part of that model, or is it, extended hours? How do patients get the kind of urgent care need as part of that primary care?
Yeah. And I would kind of toss it back to the way that primary care used to be. Mm-hmm. For people that are old enough to remember, like myself, there was a day and time when your primary care provider took care of you and your family. They knew a lot about you. You had a relationship with them. They were typically independent. They just owned their own practices. Mm-hmm. They delivered babies. They helped people at the end of their life and everything in between, and that was primary care. And I think most of us know, what happened was health systems realized, hey, these primary care providers are the ones that are really making the referral decisions on where they're sending patients for care. And just from a business perspective, health systems started buying primary care practices because if they own the practice, they could have influence on where they sent patients. Which from kind of a business model and administrative model, that makes a lot of sense. From a patient-centric model, it actually doesn't make a lot of sense, right? And so what we've seen kind of in recent years is these other, some people call them direct care models. Concierge is an example. So mm-hmm. where a physician has gone out and become independent again, working directly with the patient. In the concierge model, really it's a fee-for-service model with a monthly access fee. So a lot of those types of providers, they're seeing a much smaller panel than what you would typically see in primary care. Just to give you an idea, traditional primary care providers generally carry about 3,000 patients on their panel, which translates to, they see about 40 patients a day, which then translates to the average face-to-face time in primary care is about 7 minutes. The concierge model, they carry many less patients, usually around 500 to 800 or so, which gives them time. So their patients have access to them typically around the clock. When a patient needs an appointment the same day, typically there's openings just because they're not carrying that level of patient load. But at the end of the day, they also bill insurance, right? And so there's some different pieces of that. The direct primary care model is actually just maybe one step further removed in that they build a patient panel of typically around 1,000 to 1,500. They're not billing insurance. They're charging a flat monthly fee, a per member per month fee. And then everything that they do kind of in that model is included in that monthly fee. So a lot of them, certainly the preventative care and urgent care, sinus infections, it's all included. A lot of them dispense medication on site. They do labs on site. And so they'll include those things within their model. When we started Practice MD, our perspective was, employers are really in the driver's seat to transform healthcare. because most people get their health benefits from employers. So employers are the ones that are really paying for a lot of the care. And we borrowed some of these key differentiators from the direct care and the concierge practices in that our providers need to build relationships with our patients. And to do that, they've got to have time, right? Again, the way that it used to be, like we want to know our patients, social lives, what's happening at work, what's happening with your family, because all of those things influence your physical care, right? And so our providers typically carry about 1,000 patients on their panel. It depends on the acuity of the population. We want to make sure that our providers can have time to spend with the patients in the way that they need. And most of our appointment times are about 30 minutes long. So our patients are able to sit across from their provider for 30 minutes and get to know them. And that relationship base, it puts primary care at the center of the healthcare neighborhood. And when primary care sits there as the influencer or as the guide to the healthcare system, you can help patients navigate to the right care at the right time. And then also just take into account the right price, right? And so as we're partnering with employers, because they're the ones that are paying the bills for a lot of healthcare, the financial component, I'll say it again, it's an outcome from taking great care of patients. When you provide the highest level of care, people actually move towards health and they cost less money.
So I think that's really interesting, and just to kind of make this relatable from a personal perspective, because what you went through those different scenarios, and it made me realize complete disconnects I have in my own primary care, if you will. So I have a primary care physician that's part of a system, right? And I basically see them maybe once a year for a physical. But then I see it's sort of like a concierge medicine doctor, more functional medicine. And I see them maybe 3 or 4 times out of the year, but I have to go somewhere else to do labs. They may prescribe meds, but I have to go pick those up somewhere else. And they don't use insurance, so I'm paying fee for service there. But it makes me realize how disconnected everything that I have on the primary care side personally is. And so your solution is really interesting because it's kind of that in between for the patient panel to be able to get the time with the patient. They probably feel like they're being listened to, but you also have the conveniences of labs and meds right there as well. So it made me reflect a little bit about my experience with primary care.
Mm-hmm. 100%. And I remember, especially in college, I remember thinking, boy, I sure am jealous of those folks that have a mom or an uncle that is a physician, right? Because they just have somebody to call all the time if they have question about a medication or, where they should go to seek care. And, in some ways there's some similarity. Like we want to connect patients to physicians and make it convenient for them to interact with healthcare. So our patients have access outside of health center hours to their provider. So we get some calls after hours of, hey, I'm not feeling great. Should I go to the emergency room? We're able to guide patients on what to do, when to seek care, and when to come to us.
Yeah. So, patients these days, right, they have more and more expectations of their care provider, right? Whether it's the hospital, we're talking about primary care providers in this forum here today. And, these expectations, if met, lead to more patient retention for that clinic, more patient loyalty, et cetera. Many drivers, include quick access to appointments, more time with your caregiver, convenient location. I know that's, I think, a great example for you with your business model. Improved customer service, technology, cost, transparencies, clear bills. The list can go on. I know you mentioned a few examples there where, you're building relationship with your patients, with your providers. You're seeing more time with your patients, right? You're guiding the patient through that continuum of care, as you said. So, beyond those, really, how does your care model speak to some of these other expectations that patients have, especially around the billing, technology side, and transparency side? And then also on top of that, have you discovered, other loyalty and retention drivers that early on as you're building your business, you weren't really quite aware of yet, or you weren't focusing a lot of time on that? Now you're aware that you need to really put some eyes on.
Yeah. So I kind of speak to that from 2 ways. One, just on the operation and how we've designed the experience in the health center, but then I also want to speak to the care model and members of our care team that are actually in place to drive engagement into our health centers. So if you go to almost any healthcare facility in the US, there's a pamphlet or a sign or there's a painting on the wall that says something about patient experience, patient-centric, patient first. And I kind of chuckle to myself because we've all sat in that waiting room 45 minutes after our appointment time, and we're looking at a sign that says, we always put the patient first, right? And boy, it doesn't feel that way. In our world, kind of when we started Proactive MD, we asked the question, what's it like to sit on the other side of the table from a primary care provider? And how can we make that as easy to access and as supportive as we can for our patients? So we did a lot of roundtable discussions. We did a lot of surveys, collected a huge amount of information. And all the things that you just mentioned came up. The number one dissatisfier in healthcare was waiting. Which I can relate to. I think many people can relate to. So in our model, part of this smaller patient panel is when you come into our health center, you're greeted by a nurse, and then they take you back to an exam room. And then the provider comes in. So there's no 45-minute lag between when you set your appointment and when you get to talk to the provider. We took it steps further, and we really designed from the time you enter the health center to the time that you leave. We're very intentional with what we do. And I'll give you a couple examples. One, I mentioned when you walk in, there's a nurse that stands up and greets you. Welcome to Proactive MD and takes you to an exam room. Have you ever been in a healthcare setting where you walk in the door, there's a waiting room full of people, and you walk up to that administrative person behind the desk, and they're buried behind a computer, and you feel like maybe you're a distraction and you don't really know what to do and where to go, and am I supposed to sign in?
Right there on the phone.
World, yeah, 100%. Yeah, in our world, we're actually expecting you. Come on in, let's get you taken care of. Our providers are in the exam room, they're doing what we call open charting. So there's actually a screen on the wall that your health chart is projected on, and it does a couple things for us. One, it makes sure that you're engaged kind of in what we're talking about, that we're talking about the right things. We also often get feedback that, hey, I'm not taking that medication anymore, or hey, that procedure was on my left knee, not my right knee. And so for you, the patient, we want you to have a complete medical record. And that's some of the information that we got of, man, it's so difficult to get providers to talk to each other. Well, we want to be your medical home. And so we ought to have the most accurate record of your healthcare to share when we send you beyond the walls.
I think that's a great point. I'm sitting there in my exam room as a patient, peering over my provider's shoulders, wondering what he or she is inputting about me as I, tell him what my problems are. Right?
Or how they translate it from my layman speak to their very, medical jargon. Did it translate correctly?
Right.
Yeah, I wanted to add a layer on that, Troy. You were talking about since I work really more on the real estate aspect of it and the facility side, but one of the things that always I found attractive when designing is the first thing we really do prior to even signing the engagement letter with the client is we talk about their facility, what are the comforts of their daily work life or their daily living life, and how can we incorporate that into that? And examples are all over the population that we have, whether it's working inside of a school, because that's where the population is, and we set up actually inside a school, or we go out to a remote plant. We design and build a modular unit that's right next to their workout facility and their HR that they can walk over any moment, but they see every day while they're working through their daily lives. Or if it's more of a freestanding design, in many cases we incorporate their children's artwork on the walls. We have photos from maybe different plants that they have around the country. So it's a comforting feel when they come in there, and that's I think a real different experience than you would have when you walk into a Doc in the Box down the street.
Yeah, you're really trying to customize it to their people, their culture, their community, and what's important to them, right? So
yeah, I always one of the favorite examples is we have a plant that has a very they speak Spanish, and we wanted to really engage them, and they figured the best location for this for this facility would be right by the lunchroom, where they come in and out constantly every single day. We walk by, we can say hello, they can stop in, they can see us, and they feel comfortable about engaging with us, which is, ultimately what we want, to be engaged.
So I would say too that as we've designed our care model, engagement is a huge driver of our success. So if employers hire us to help their population get healthier, which one of the byproducts is financial savings, people need to use primary care, right, to start moving that direction. So certainly some of the things that Charles mentioned, being sensitive to the space and how we interact and making it accessible. We also have patient advocates on our care team. They're actually in our health centers. These folks they're social workers, and we chose social workers very much on purpose. And kind of their primary goal when we start a health center is to engage the population. They do this by building relationships. So they're out and about, they're interacting with patients, they're doing outreach. And what we often find, in our world, the social determinants of health have really come to the surface of all healthcare conversations. And what we see in our world is, hey, we've identified that there's some patients that really ought to be interacting with care, and they're not. And oftentimes it has nothing to do with their physical care that's keeping them out of the clinic. Usually it's something else going on. And social workers are perfectly positioned to meet them where they are. And we have story after story where, a patient was struggling financially. And we were able to come alongside of them and connect them to resources to then engage them in care. Or a patient is in a difficult relationship, and there are resources that we can connect them to meet them where they are. Most people don't think about going to their primary care clinic because they're struggling financially. We want them to think of that because health is not just physical, right?
Absolutely. That's a great point. So I want to chat a little bit about the design care environment, and also give a little bit of my own experience in the past with some primary care and also specialty providers as well. We know from research, and it's just common sense, I believe, too, that it's, the design care environment has really been identified as a significant driver of patient satisfaction. Things like just in a primary care environment, clumsy exam room designs, uncomfortable waiting room chairs, waiting spaces that aren't designed to accommodate wheelchairs or walker access, even lighting in the parking lot, closed parking lot, et cetera. All that taken care of, though, it still doesn't speak to, I think, opportunities that patients have to be concerned about privacy, in their clinic. And so, I was just thinking about this as I knew we were preparing for this podcast, and also visiting some clinics as a patient, as well as in a professional environment too. I know it's not uncommon to hear candid conversations, going on between other patients and their care providers. Conversations in the hallways, or care providers actually providing some sort of care in the hallways, or exam room doors, not being completely closed. So, right, privacy concerns, abounds. So, I've seen this as a patient, but as a patient, I hardly ever run into another patient that I know personally or professionally, right? So I'm not concerned about, a candid conversation with my physician or mid-level provider being heard by someone else that I might be concerned about. But in your situation, I think there might be a perception that a patient maybe in an on-site clinic of yours might be concerned about having that candid conversation with their provider when they know that every other patient in that clinic is, potentially a coworker or someone they know. So how has Proactive MD recognized that potential issue and, provided some solutions so that patients do feel comfortable truly sharing their healthcare concerns with their providers?
From a physical perspective, and the facility layout itself, we've got several things that we incorporate in that. One is try to incorporate, some of those basic things you hear, Muzak, insulation, which helps. I think it starts from what Troy stated earlier. Our population we don't have waiting times, so we don't usually have that lobby concern where you're seeing a lot of people. We also, the way that we structure our times with the patients, there's not a stack up. There's not like all the exam rooms are full and they're waiting for the doctor. So we know how to structure that. So that's one, just the organization of how we operate. But from the physical side, we try to get creative when we can. Obviously, sometimes there are barriers within the facility, but when we can, by example, we had this come up with a professional setting where executives and or other coworkers, they didn't want to have that, what you just described. So what we designed was there's an entry and an exit. So in the flow of the entire, from the time they come in, meet, to the lab, to the restrooms, to the exam rooms, and then there's a nice exit that they go out through. So there's a kind of a checkout. So it's almost like a straight line, if you could. And I think that was kind of intentional for them, that they wanted to kind of keep that patient care very private. Other times there's not those concerns, but when there is that physical aspect of it, again, we're not waiting as long. I don't think there's exam rooms that are sitting full waiting for that, because we have designed time frames. But we try to put music, we try to put the insulation in there, because that is a concern when you have voices that can be heard, whether it's out in the hall with anyone, or whether it's a patient in another exam room. So, but some of those designs we do consider regularly, and it's mainly around the flow. You come in this way and you exit out this way.
So I want to kind of piggyback on this conversation about the design, and perhaps also the conversation we had just a few minutes ago about customizing the facility to the culture, the community. I'm curious, as you've done these, just like anyone, you learn over time, right? So there's always the continuous improvement. What are some of the things you've learned to be tried and true, the things that are standard, that prove to be successful everywhere? And then what are the things that you've identified that are truly the customizable things to make things specific to an employer and their particular needs, or things you've just learned over time that said, we can do this better. This is how we're going to do it better.
I think the first key component of that is engaging with the population and the key stakeholders from the beginning. Mm-hmm. So before we ever get started, usually, depending on whether they want to have the facility on site or whether they want to have it down the street, there could be a variety of different options there. They will engage us. They'll talk about their population. They'll talk about what their model, what they would like to see in the facility. So we start gathering that information in the design part of it. And that includes things like, how would you like the design to look? Would you like to incorporate those pictures that we talked about? Would you like for us to come up with ideas? What would the colors look like? Do you want to incorporate your logo? Do you want to incorporate our logo? And those are interesting discussions, because sometimes they really want it to be a PMD type facility, and we have a template that we can give them. So that it feels like a traditional, more doctor's office. Or sometimes we'll say, no, we really want it to be designed around, what our team is, work with our contractors, work with our design group. So we start with that. And then they will send, many times I'll go out, if I'm looking at the site, I'll go out prior to engagement. I'll go on the facility. I'll go look at real estate. I'll visit with different key decision makers, and we will start selecting that location. And that location is based upon where the population is living, or we think that it'd be better to be on site or near the site, because that's where we're going to get the greatest engagement. As we go through, those designs are all to take into consideration. To answer your part about the standards, yes, there are certain standards that we want to have in every room. But one of some of the key takeaways, as Troy mentioned, we want to have a TV in the room that we can cast the chart. So that's really become a standard for us, that we try to ensure that all the employers want that in their facility, and we kind of really encourage them to do so.
I love that. I've yet to see that with any of my providers.
Yeah. Well, a lot of them play. I just went to one, and a lot of times they'll play Disney Channel on there.
Well,
So
sure, but I've never seen a screen that displays my own chart.
No, never seen it.
Yeah.
yeah. One of the other things I like is that we've started to do more is we design almost a double exam room. So when you walk into the exam room, we have a small sitting, comfortable area where we can sit down and just engage each other. There's typically a half wall, and behind that wall is your traditional exam room. So this is nice for multiple reasons. If you wanted to engage and just sit down and talk, you may not really need an exam. You may want to just be talking about something. You can sit into an exam room and just have a comfortable atmosphere. There's a TV there as well. If you wanted to have an exam, let's say you have a young child, but the mother wants to be in the room, but you want to have that privacy, they go behind the wall. They can still talk and engage, but there's a private area for the parent to sit, and the exam can take place on the other side. So I really like that. And I think we're incorporating that more and more when the facility and the client, finds that to be a benefit for us. So those are some new items that we're doing.
I want to say how much I appreciate that as one, a woman, but two, who has kids, but two, as an individual who, when I usually go to my primary care doctor, most of the time, I never even have to get on the exam table. I sit in the chair, the guest chair that's next to it, and the doctor rolls over to me, and we're most of the time having discussions. They may, do my vitals and things like that, but it's discussion based, and very rarely do I have to go on the table. So it's a much more comfortable environment, and I feel like I could share more with my provider in
Sure.
that setting.
I stand in the exam room and put my laptop on the exam table and wait 25 minutes for the provider to come in and work.
Good time to get emailed.
That's right.
That's right.
Yep. I said, wait, can you come back in 5 more minutes? I'm almost done with pushing this email.
Yeah, I also wonder about that. So some primary care clinics, you mentioned kind of the word medical home, right? And so that word sometimes makes me go back to a medical home model where sometimes you have integrated behavioral health or physical therapy. So kind of thinking ahead here, how does that work in integrating some of those services, or is it referral based? What does that look like?
Yes to all. Really, it goes back to what the population that we're serving needs.
Okay.
So as we're working with the employer, as we understand, for example, that, hey, we have a lot of musculoskeletal challenges with our population, we will have the discussion about physical therapy. Should we bring a physical therapist on site full-time? Should we bring a physical therapist on, a couple days a week? Or should we find a great physical therapist in the community that we can have as a resource to lean on? It really is dictated by the patient and the client need. But you're exactly right. If you're working directly for patients and there's not misaligned incentives that are associated with some traditional healthcare models, you really are able to build a custom solution that meets people where they are.
Sure, as you've got clinics across the country, correct?
That's right.
So with your varied locations, and you've probably got multiple and varied aspects of social determinants of health that are important to each of those regions, right? So I wanted to go back and ask your employer type demographic. What you mentioned schools before. You're probably in manufacturing sites as well. Is there a sweet spot that you found that you've in most often, manufacturing sites, schools, other types of employers? And then how does your clinic size vary with your on-site clinics? I'm really interested in that as well.
Oh, yeah.
Yeah, as far as clients we serve, it really does run the gamut. And the qualifier for us is where the people are. And you mentioned schools and you mentioned manufacturing. Those are natural fits for us because there's a lot of people in one spot. Mm-hmm. We do a lot with municipalities and governments. Similar reasons. We do have food processing and food manufacturing. We work with some technology companies and some financial institutions. And again, the common thread is there's a cluster of people in one space that we can take care of. As far as just the health center designs around the country, on-site versus off-site or near-site, you do have some parameters. And, I'm sure Charles is smiling. You do have parameters on limits of space, right? When you're working in an automotive manufacturing facility, every square foot has a dollar value, right? And so they may not give you 5,000 square feet to build a clinic. However, I will say that we are very creative on how we can get the most out of a space. I would say on average, our on-site health centers that have one provider and a one provider care team, typically they're around what, Charles, 1,200 square feet or so, and we've got some that are smaller and we have some that are much bigger.
We've gone probably as low as 400 or 500 square feet, depending on if we're engaging them every day. That's another thing, is that the schedule could say, hey, we only need a two times a week, and that's when we are engaged, or whether it's a full service, and the model and the number of employees. But we have clinics from probably 400 or 500 square feet to, like you said, about 5,000 square feet. That's our range.
Yeah, so I guess it's flexible and specific to, again, what the population is. And
yeah.
When we talk about lessons learned on design, I will say, I don't think we have any health centers that say we have too much storage space, right? And so over time, we continue to add more and more and more to make sure that we've got plenty of space.
Oh my gosh, I that's like the number one thing I hear every time I go to a new facility and ask them about what works, what doesn't work. Well, we need some more storage.
More storage,
Yeah.
more restrooms.
Yeah. Kind of putting myself in the patient's shoes here. So let's say I come to my primary care clinic at my facility and I need something else, right? I need, let's say I need a neurologist and I'm trying to evaluate having some kind of procedure done. How does my primary care doctor at PMD, how do they connect me with the right person, the right practice in the community to get me the right care at the right cost? But they're trying to extend that value. How does that happen?
It's a great question because it's so unique the way that we do it. In a traditional healthcare setting, if your primary care is owned by a health system and you need a referral to another specialty, there's a very high chance that you're going to go to a specialty provider within that health system. We work for patients, right? And we work well and we are friendly with health systems, but our incentive is we want our patient to go to the best care provider of the highest quality available, no matter what health system that provider is part of. And so we've got a very robust data and analytics team combined with a population health team that has quality tools to where we can actually look across a geographic area and locate the highest quality provider based on specialty. We've partnered with TPAs, we've partnered with insurance carriers to acquire some of the similar information. And so when we refer a patient out, again, if our goal is the highest quality and best outcomes, we want to steer them to the right provider.
Mm-hmm. Coming full circle back to that initial, and the initial answers you talked about in the model, and what is your why, and kind of was curious about that next step when a patient has to leave your facility and go to another facility. How do you kind of close that loop?
I'm struck by, the need for us in healthcare to help our community improve the management of our own health, and I think one of the ways to do that, right, is to understand where the patients are, right, because I'd rather not go to my physician if I don't need to. Telehealth, I'd love to do that, et cetera. But, we in healthcare, I think, need to recognize where are the patients most of the time? They're at home or they're at work, right? And we see healthcare systems beginning to invested in that hospital at home model. I think you at Proactive MD have taken it to the work site or close to work site, and I think that's really going to do a great, give a great opportunity for our patients to really help invest in their own care because it's going to be more convenient for them.
Well, I think it too, when you want to get compliance and you're invested in making the population well, it goes back to some of the changes that are happening in the public health side as well, because that's changing and it's becoming less public health facility focused, and they're really trying to get out into the communities and connecting with the populations that are at risk and don't have access, or it's a cultural connection, that's a language barrier, right? So they're going to the churches, they're going to the schools, they're going to the big employers to make those connections. So when you talk about, the being partners with a government, that's kind of that piece too. So I see how it all kind of starts to work together in a kind of a spider web. Well, thank you very much, Troy and Charles, for joining us.
Thank you.
Thank you so much.
And now it's time for our pulse check, where we'll cover a couple of takeaways from today's podcast episode. So, Mike, we have, I think, probably 4 takeaways. What do you think? What do you think the first big one is?
I love this one here. It's to me, it's providing better geographic access to primary care, enables patients to be more proactive about their health.
So I also think a second takeaway is that this model of care, it provides a level of trust for the employees with those providers, right? And so they feel like they're getting really the best outcome that they can, whether it's at this PMD location with that provider or whether it's a referral to a specialist, for additional care that they're going to need down the road, right? Because they're focused on the quality and outcomes of particular providers or particular procedures that a patient may need.
Sure, and I like that level of trust also comes from the perspective of the physician or the mid-level provider being able to spend more time with that patient in that clinic. These are typically, I believe, smaller clinics than your average large primary care physician clinic that I know I see. And so, you can help build that trust also because you're seeing that same physician or mid-level provider or social worker over and over and over again. So you do build that personal relationship with them.
The other thing too, especially with the social worker being in there, I think they're focused on the facility and the design of the facility, but not just from what's an efficient way to design it for what they're doing and seeing the patients, but also in a way that they're able to customize it to whatever that employer truly needs, right? They have different numbers of employees. They may need care 1 day a week, 2 days a week, or 5 days a week. And they may be employing specific populations that you may have to make some design changes for, or really make it personal to them and connect with them culturally as well.
An employer may be, for example, a manufacturing site, which may need to speak to some of the more physical concerns about patients' musculoskeletal than maybe an employer that's more office-based.
All in all, I think really what it comes down to is that a healthier patient makes a more productive employee and ultimately is less cost for an employer. And it's reducing their operating costs because they know that their employees are healthy, right? They have care available to them when they need it, and they're there to support them.
And I'm interested to see where this model goes in the future.
Yeah, me too. Thank you for listening to Ideas Shaping Healthcare by Idea Exchange. If you have any questions on this podcast, you can find our contact information via the link in the description.